The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Sanford here to review the management of all things acute pancreatitis. Dr. Sanford, welcome to the podcast.
Hi, Katharine. Thanks for having me. My name is Dominic Sanford. I am a hepatobiliary and pancreatic surgeon, and it's great to be here today.
And I'm Katharine Caldwell, Chief Resident in General Surgery here at WashU. Today, we're going to be talking about acute pancreatitis. Acute pancreatitis is an acute inflammation of the pancreas, which can range from mild symptoms to severe, with resultant organ dysfunction. While 80% of patients will only have mild to moderate symptoms, the development of severe symptoms can put patients at a 20% risk of death. Let's dive into a case scenario that will serve as our template for discussion today. A 45-year-old male presents to the ED with acute onset abdominal pain. The pain is located in his mid-epigastrum and has been present for about the last day. The pain is very severe and radiates to his back. How would you make a diagnosis of acute pancreatitis?
Well, one of the most common criteria used to diagnose pancreatitis are the Atlanta criteria, which involves the presence of two out of three symptoms, either upper abdominal pain, a threefold increase in amylase or lipase, or radiographic evidence of acute pancreatitis. And this is usually in the form of a CT scan, which can often show peripancreatic fat stranding, as well as peripancreatic fluid, and sometimes some of the sequelae of pancreatitis, such as pancreatic necrosis or pseudocysts.
We know that there are over 100,000 new cases of pancreatitis diagnosed each year. What are the most common etiologies of it?
The two major causes of pancreatitis are gallstones, which make up about 40 to 45% of cases, followed by alcohol, which is the cause in about 30 to 35%. Determining the etiology of pancreatitis is very important to both prevent future recurrence as well as to avoid potential complications of acute pancreatitis. In addition to those two major causes, other causes include things like iatrogenesis. For example, ERCP can be associated with pancreatitis in as many as 5% of cases. Some infections, certain medications, especially when someone who started a new medication recently, as well as trauma, autoimmune conditions, and hereditary conditions.
Our patient undergoes additional laboratory investigations and a CT scan, which demonstrates cholelithiasis. His labs are notable for an elevated white blood cell count, elevated bilirubin, as well as ALP. What are your next steps in management?
Well, first of all, I would really examine how elevated these levels are. Acute pancreatitis alone can cause a mild elevation in bilirubin and alkaline phosphatase levels, and this is due to edema involving the ampulla. If the levels are significantly high and not going down when trending them, then we do something to evaluate for possible stone impaction in the distal common bile duct. One could consider performing an MRI with MRCP as a less invasive way to evaluate for this, or could proceed directly to an ERCP with stone extraction, though you do have to worry about the possibility of worsening someone who has an ongoing acute pancreatitis.
The patient is admitted and undergoes an ERCP and extraction of several stones in the common bile duct. Following this, his laboratory values do begin to improve. What supportive care is offered for this patient for an episode of acute pancreatitis?
Well, most cases of mild acute pancreatitis are treated with simply supportive care, such as IV fluids, ensuring appropriate nutrition, pain control, and monitoring for complications of pancreatitis. For patients with mild acute pancreatitis, we know that enteral nutrition is best as opposed to parenteral. Enteral nutrition is associated with a decreased risk of multi-organ failure and death in these patients, and so we prioritize oral or enteral nutrition when able.
For a patient like this who has an episode of acute pancreatitis as the result of gallstones, What is the recommended timing to cholecystectomy?
Cholecystectomy should ideally be performed during the same hospitalization to prevent future recurrent disease. Now, some patients will have sequelae of this and can have necrotizing pancreatitis or complications. And in those patients, we will perform an interval cholecystectomy to allow for time for the signs and symptoms of pancreatitis to resolve.
We admit our patient to the floor for supportive care and monitoring. He does well and is ultimately discharged home. He returns to clinic about 4 weeks later with persistent fullness and poor PO intake. What are you considering as a cause for his inability to tolerate food, and how would you treat him at this point?
With those symptoms in that time frame, one would be worried about the possibility of a pancreatic pseudocyst. Generally, we like to wait at least 6 to 8 weeks before considering interventions to allow the wall of the pancreatic pseudocyst to mature enough in order to perform a cyst gastrostomy. Usually, in today's era, this can be performed endoscopically.
Let's switch gears for a second and talk about a patient who falls on the other end of the spectrum. Consider a patient who comes in with evidence of necrotizing pancreatitis and associated organ dysfunction. What are your initial steps in treatment of that patient?
Well, these patients usually necessitate ICU admission for close monitoring. One worries about the possibility of progression to infection of the necrosis, which can require a debridement, as well as other complications such as pseudoaneurysm formation, abdominal compartment syndrome, and multisystem organ failure.
We admit our patient to the ICU, but he continues to deteriorate, has persistent organ dysfunction, and a rising white count. What data can we use to determine the interventions we should use for patients with necrotizing pancreatitis?
Well, it can be tough. Sometimes these patients can get really sick, and it can be difficult to determine whether someone has infected necrosis or requires an acute intervention. When possible, we try to delay surgical debridement for at least 3 to 4 weeks, and we try to avoid it if we can at all costs. Debridement can also be performed endoscopically or with the use of upsizing percutaneously placed interventional radiology drains to allow for what's called VARD, which is video-assisted retroperitoneal debridement. The step-up approach, which was first described by the Dutch, showed evidence of decreased mortality compared to primary open necrosectomy.
For patients who develop acute pancreatitis, what is the long-term risk for these patients?
Well, they are at higher risk of the development of chronic pancreatitis, and that's where you can really make a difference in trying to reduce the risk factors associated with this. Such things as alcohol and tobacco cessation, again, performing cholecystectomy in a timely manner should be considered to avoid future complications.
Dr. Sanford, thank you so much for your time to be with us today. We got through a ton of great information about acute pancreatitis. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of acute pancreatitis can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Katharine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.